Good evening, everyone, and welcome to the IMS Living Well with Myeloma teleconference. It's our second teleconference this year, and tonight you're in for a treat as Dr. Durie is our speaker. And I happen to know from experience he'll do a great job in answering your questions and concerns. On this teleconference, Dr. Durie will focus on MGUS, which means monoclonal gammopathy of undetermined significance, and also on smoldering myeloma, and he'll also be speaking on newly diagnosed myeloma. So there's a lot to update you on. And at the end of this teleconference, I know that you'll feel very informed and, most importantly, empowered. So before I turn it over to Dr. Durie, I'd like to take a moment to thank our sponsors of tonight's teleconference, Celgene and Takeda Oncology. I want to thank them for their continued support of this program, and it's greatly appreciated. One last thing, as a reminder, you'll find the link to tonight's slides on our new website homepage, myeloma.org. So now sit back, relax, and Dr. Durie, it's all yours.
Well, thank you so much, Susie. I'm glad to have this opportunity to go through this first Living Well teleconference. This is a little bit unusual for us to focus on early disease, but I think it's very important, particularly since there are new testing techniques available and there is the possibility of early intervention in a variety of ways. And so if we can go to slide number 2, you can see that I've summarized what we will pursue on the teleconference today. I will start by discussing what is MGUS, that earliest point in the diagnostic chain. Then what is smoldering myeloma, and how do we understand the transition to active myeloma? And then what I think will be particularly important is where are we with the recommended treatment algorithms for 2019. And so if we go to slide number 3, what is MGUS? And this is clearly very, very important in starting to understand what is the origin of myeloma. And so MGUS is monoclonal gammopathy of undetermined significance. And so a gammopathy is the presence of a spike or a monoclonal protein in the gamma region of the serum protein electrophoresis, SPEP. And you can see with the red arrows that I'm pointing out the presence of a small spike on an example of a serum protein electrophoresis. Underneath it on the slide number 3, you will see that I'm showing immunofixation, IFE, and this is the method whereby the bands show up to identify, well, what type of a monoclonal protein is present, what type of M spike is there. In this case, I'm illustrating IgG and then lambda, which is one of the 2 light chain possibilities, the other being kappa. In this case, the protein is IgG lambda. And so MGUS is where screening or testing has revealed the presence of this abnormal protein in the blood, and this has been followed up by testing where the bone marrow has been done and has been found to contain only a small number of plasma cells. You should be aware that normally the bone marrow can contain up to 5% plasma cells. And so in the case of MGUS, that percentage can increase to 10% or less than 10% as it shows you on the slide. So what we're talking about is a very, very low level of an abnormal occurrence with an increase in the number of plasma cells from 5% to less than 10%, and then a low level of protein which for the definition of MGUS is less than 3 grams, which is also 3,000 milligrams. And of course, in these early patients, there is no indication of myeloma-defining events or what we call CRAB features, which I'll be talking about as we go along. And so if you go to slide number 4, I've listed what are the criteria which come from the International Myeloma Working Group, IMWG, and on the left, I've listed the specific criteria for MGUS, and you can see, moving to the right, I'm going to be talking later about, well, what are the comparable criteria for smoldering myeloma, SMM, smoldering myeloma, and MM, multiple myeloma. And then MDE means myeloma defining events, and of course, in the early disease patients, there are no active myeloma defining events. And so we move forward to slide number 5. What I've tried to illustrate is that this movement forward in the disease with progression is associated with underlying molecular or genetic changes. And so early in the disease, at the MGUS or smoldering stage, there are changes which are mostly linked to chromosome number 14, which is where the heavy chain for the immunoglobulins is located. And so this is called IgH, or Ig heavy chain, and then there are translocations where there are connections between different chromosomes involving number 14, with number 11, with number 4, with number 16, with number 20, for example. In addition, there can be extra chromosomes. Normally, cells will have 2 chromosomes, one from your mother and one from your father. If there's an extra one, this is called trisomies. And this is another feature of early MGUS and smoldering myeloma. As the disease moves forward, additional chromosome abnormalities can emerge. For example, amplification of the bottom part of chromosome 1, which is called 1q+, or loss of the top part of chromosome number 17, which is called deletion 17. And then if you move forward to the right, with more progressive and advanced disease, additional chromosome changes do emerge. If we go to slide number 6, I'm illustrating here, well, how common is MGUS? And you can see here that it does affect approximately 3% of the general population over the age of 50, and that the occurrence of MGUS is very much age-related, and so it increases from a lower level in younger patients to a higher level, 5% or more over the age of 70. If you go to slide number 7, I would like you to be a little bit familiar with a very, very important project which is going on in Iceland called the Iceland Screens, Treats, or Prevents Myeloma protocol, which is called ISTOP-MM, which is coordinated through the Black Swan Project with Professor Sigurdur Kristinsson at the University of Iceland as the principal investigator. And in this study, all of the people living in Iceland are screened if they're over the age of 40, which is the highest likelihood of developing a monoclonal protein or an MGUS. And what that means is out of the population of Iceland, 140,000 adults over the age of 40 have actually been identified for screening, and of those, around 90,000 have agreed to participate in this project, which is truly remarkable. A huge, huge participation rate of 90,000 patients to be screened and evaluated for MGUS, smoldering, or actual myeloma. And so if you go to the next slide, it shows you, well, what are the key early data from Iceland on slide number 8. And out of the screening process, approximately 4,000 new cases of MGUS have been identified, and this is a huge opportunity to understand who is getting MGUS, what is causing MGUS. But it's also a huge opportunity to study what are the factors linked to ultimate progression of the MGUS to smoldering and or active myeloma. Are there additional mutations? What are those so-called driver mutations? And what could be the role of some simple blood testing to monitor and assess this progression process? If we go to slide number 9, it shows you what the numbers look like over time with 1% per year patients with MGUS moving forward into smoldering or active myeloma. This means that there are 40 new cases a year, or 200 cases after 5 years. And so rapidly, if you have 4,000 patients with MGUS, then you can end up with a lot of patients with myeloma, and the ability to evaluate the molecular and immune processes which are leading to this progression process. If we go to slide number 10, this illustrates what is going on related to the MGUS. And so there are two aspects to the MGUS. The first one is that every patient who develops myeloma has previously had MGUS. And so this is something that was learned from a very, very large database screening trial study and was published in the journal Blood in 2009. And from a very, very large study population, we learned that 71 patients with multiple myeloma, everyone in the stored serum samples where monoclonal protein was tested had previously had MGUS. And so MGUS always comes before myeloma. But what is very, very important to understand, if you go to slide number 11, MGUS is linked to many outcomes. So what this shows you is that although everybody with myeloma did previously have MGUS, it also illustrates that everybody with MGUS does not get myeloma. MGUS can turn into myeloma, which is on the left-hand side of this slide number 11. Patients with MGUS can develop myeloma, macroglobulinemia, other types of plasmacytomas or plasma cell disorders. In the middle part, you can see that patients with MGUS can also develop amyloidosis or other types of situations where light chains are deposited in tissues, or even can have problems related to the temperature of the protein, where there can be cryoglobulinemia, where there are problems which emerge with cold temperatures. But really, really importantly, over on the right-hand part of this slide, you can see that patients with MGUS are also at risk for other kinds of problems, where the myeloma protein, the abnormal myeloma protein, can lead to neuropathy, to nerve damage, to skin problems, also kidney problems. A variety of other diseases can be linked to this protein, even although myeloma or amyloidosis per se has not developed. So very, very important to be aware of those possible medical problems that may actually require medical attention even in the absence of developing myeloma. If we go to slide number 12, it illustrates what are the factors that lead to a likelihood of the MGUS progressing. And the important factors are the size and the type of the monoclonal protein, and also the status of the serum free light ratio, the light chain level in the blood, the level of the free light chain in the blood. And so what is called low risk, or with a very, very low risk of progression forward to smoldering or to active myeloma, that's at the bottom of this, and you can see over 20 to 30 years, very, very low risk of progression. These are patients where the M spike level is less than 1.5, where the protein is of an IgG type, and where the free light ratio is normal. Conversely, high risk is where the protein level is much higher, is perhaps not IgG, and where the free light ratio is clearly abnormal. If we go to slide number 13, this moves us into the area of smoldering myeloma, where the different levels are indeed higher. And so you can see for smoldering myeloma, the percentage of plasma cells in the bone marrow is more than 10%. The protein level in the blood is greater than 3 grams. And in addition, there could be protein in the urine at a level of more than 500 milligrams or half a gram per day in the urine. Although, importantly, there are still no more serious myeloma-defining events such as bone lesions, anemia, kidney problems, or increased calcium, the CRAB criteria. If we go to slide number 14, this illustrates what are the differences in terms of likelihood of progression of MGUS versus smoldering myeloma. So if you start off with these higher levels, with more plasma cells in the bone marrow, with a higher level of spike in the blood, or maybe protein in the urine, the likelihood of progression in the top curve, which is the smoldering myeloma, is much greater than for MGUS. And so, as you might expect, the chance of developing myeloma is really significantly higher. And so, if we go to the next slide, this shows you, well, what are the percentages? And so, if the smoldering myeloma is more at a higher level, what we call high-risk smoldering, then there is indeed a 25% per year risk of developing myeloma, which is much, much less, 5% for patients who have low-risk features. And so if we go to slide 16, what are the factors that would distinguish between high-risk smoldering and low-risk smoldering? And so I've listed here some of the factors, and particularly important are starting at the top of the bullets. The plasma cell percentage is obviously more than 10%, which means that it's not MGUS, it's smoldering. But if the protein is more than 3 or 4 grams, that is a risk factor. But number 2 is possibly the most important because it is a criterion that is used by the Spanish group that has had a particular interest in smoldering myeloma. And this is looking at the percentage of normal plasma cells in the bone marrow. So as the myeloma builds up, the number of normal plasma cells decreases. And this is linked to something that is called immunopoiesis, where the number of normal plasma cells is low and their ability to produce immunoglobulins is low, and so the levels of immunoglobulins are also low. And so this is a category that the Spanish used to identify a higher risk smoldering myeloma. Other features here, a very significantly increased free light ratio, abnormal chromosomes, changes over time, which is called an evolving pattern, and also circulating plasma cells in the blood. Now, through the International Myeloma Working Group on slide number 17, I've listed some new criteria that we've come up with from studying several thousand patients with smoldering myeloma, asking the question, out of these smoldering myeloma patients, which are the ones that are likely to progress within 12 to 18 months? And the answer to that question has turned out to be if you have 2 or more of the features listed on this particular slide. So if the protein level is higher than 2 grams, if the bone marrow percentage is more than 20%, and if the free light ratio is more than 20. And this is called, in a simple fashion, the 2-20-20 formula. And we've also noted that in addition, if you have abnormalities of chromosome number 1 or 13, this does give an added risk. We are in addition looking at a number of other factors, but for now, the 2-20-20 seems to be quite useful. And if you go to slide number 18, this shows you what is the risk of progression for smoldering myeloma for patients who happen to have this 2-20-20, 2 grams, 20%, 20 ratio, plus some chromosome abnormalities. And you can see that a substantial percentage of patients will develop active myeloma within that 12 to 18 month time frame. And so if we look at this type of population using those criteria or the Spanish criteria, there have been a number of studies done, and one of them is quite important from the Spanish team in slide number 19. This is a study that was led by Professor Marrow Mateos from the University of Salamanca in Spain. And so she took those high-risk smoldering patients with 2-20-20 or that immunosuppression feature that I mentioned, and so then those patients were randomized to be just observed or to be treated with lenalidomide and dexamethasone, Revlimid and Dex, versus just being observed. And what she noticed was that obviously the treatment group did much, much better and were at a much lower risk of progressing. And then if you go to the next slide, slide number 20, you can see that this, at the 4 to 5 year time point, resulted in a better overall survival for the patients who had received the lenalidomide and dexamethasone treatment. And so this was the first study to show that intervening early in patients with high-risk smoldering myeloma could give important improvement in remission and overall survival. And so this has led to some algorithms for how smoldering multiple myeloma should be handled. And if you have the low risk, obviously you would observe such patients with a 5% year-per-year risk. For the higher risk, you do have an option of clinical trials or to consider off-study use of that Revlimid and Dex, which did seem to be helpful. And so something to obviously discuss very, very carefully with a doctor who is monitoring these various test results rather closely. If we go to slide number 22, this moves into a huge new area of research, which is that if you have the opportunity to intervene early and treat high-risk smoldering multiple myeloma, there is an opportunity to do much, much better with treatment that is designed to really attempt to eradicate the myeloma at this early time point before additional chromosome mutations have occurred. And this is the basis of what, through the Black Swan Research Initiative, we have called the CURE trials. And from a diagrammatic standpoint on slide number 22, what we are attempting to do is to reach to the bottom of the iceberg to get rid of as much of any residual myeloma as at all possible, and use special testing to see how far down the iceberg we are. And this is where we use this minimal residual disease testing to see how much of the iceberg is left, looking for what's called 10 to the minus 6 negative, for example, which would be 1 out of 1 million cells, or even less than that. And so let me just show you with the next few slides what has been happening with those two studies I list there, the CESAR trial and the ASCENT trial, which are our first two CURE trials. And so slide number 23 is the European CURE trial, the CESAR trial, and this utilizes KRD, Kyprolis, Revlimid, and Dex, autologous stem cell transplant, followed by some consolidation, and then maintenance for 2 years with Revlimid and dexamethasone, monitoring for minimal residual disease all the way along. And so at the early time points, 62% of the patients in this trial achieved MRD negative at the level of 0 out of 1 million cells. So 1 million cells were tested, well actually more than that, but to come up with this assessment that the number was 0 out of 1 million. You need to look at more like 10 million to reach that statistical assessment. And so if we go to slide number 24, thus far with follow-up, which is now out to, I say 28 months there, it's actually out to around 3 years now, 94% of the patients are in remission with the 3-year follow-up, and so high level of MRD negativity and patients doing unusually well with this very important early intervention. And so if we go to slide number 25, this shows the U.S. CURE trial. This is the ASCENT trial, which is led by Dr. Shaji Kumar from the Mayo Clinic, along with myself leading this U.S. study. And this adds to the KRD treatment with daratumumab, the monoclonal antibody against CD38, and this is given to try to increase the likelihood of achieving MRD negative at that 1 in a million level. We also will be opening up the option for autologous stem cell transplant in this trial. There will be the consolidation and then 1 year of maintenance. And you can see on the left of slide number 25 the sites across the U.S. where this trial is currently open. As I understand it, there's 16, 17, 18 patients now accrued in this study, and everything is going quite well, with patients already starting to achieve MRD negativity with this trial. And so what do we expect? What are the current expectations on slide number 26? What are the current expectations with this type of important early intervention? With the CESAR trial, 62% undetected minimal residual disease. We don't know yet what the numbers will be with the addition of daratumumab to the 3-drug regimen, the DARA-KRD, the ASCENT trial, but we're estimating at least 75%. And so really high expectations that this can produce some really excellent outcomes for patients with myeloma. But to emphasize this, these are pilot studies. There were 90 patients treated in the CESAR study, and there will be 90 patients treated in the ASCENT trial. So these are pilot studies to really assess what is the safety and the benefit of this type of early intervention. If we move forward to slide 27, I want to take us forward to where are we when patients actually develop myeloma. And so the first thing is that we need to expand the amount of testing to clarify if patients do have myeloma-defining events or indeed have some clinical features, some CRAB features. So I've listed there the 7 categories of tests on slide 27 that you need to assess if active myeloma is truly suspected. You need obviously to test for the M spike in the serum and in the urine. You need blood counts, chemistry panel, free light, beta-2 microglobulin to assess the ISS staging, of course a bone marrow where you would do chromosome testing, and of course imaging, x-rays or scans of the bones. And so the next chart on slide number 28, I think, is a very, very helpful summary to look at baseline testing results and how this would influence the diagnosis. And so for the early disease, just based on the SPEP and the free light and the bone marrow, you could have an MGUS. With some additional testing, you might be able to diagnose high-risk smoldering, but additional testing is required to reach a diagnosis of myeloma-defining events. You need to know the kidney function, creatinine clearance. You need to have MRI indication to see if there are any early marrow or bone lesions. And then you need to assess the calcium, the blood counts, etc., to see if there might be CRAB criteria. And so how do we proceed? Well, in 2019, it's important to be aware that there are recommended imaging techniques beyond the use of traditional skeletal survey with x-rays. And so on slide number 29, I illustrate what are the new recommendations for the use of whole body low dose CT in yellow, and this is definitely the best technique for early screening for bone disease. You can pick up very small lesions with this whole body low dose CT technique. If you want to assess response, then PET-CT is the best, and so it's helpful to have a baseline PET-CT so that you can compare the areas of active disease at the point of follow-up. And of course, using MRI, MRI is actually the gold standard for assessing the amount of bone marrow involvement throughout the whole bone marrow skeleton. And so on the next slide, slide number 30, I illustrate if you are using these imaging techniques as part of an organized staging process, this shows you what does it look like on a PET scan or an MRI. And so on the left, you can see the bright red imaging, which shows a patient that has widespread involvement and uptake of the sugar at the site of the positive PET scan throughout the spine and pelvic areas. And if you look over on the right for that same type of patient with black and white imaging, you can see that using this technique, you can actually pick up the focal lesions, so spots in the neck, spots on the rib, spots in the spine. And then in the middle, you can see that with MRI, those areas of positive uptake look a little bit different on the MRI, and it's not so easy to visualize the amount and extent of the involvement with MRI, but it is quite precise and is a helpful way to look at the distribution of involvement. Now, in addition, at the baseline, as we're studying myeloma, but as I mentioned also with MGUS and smoldering disease, it's quite important to do genetic testing of bone marrow cells, which I illustrate in slide number 31. And so the standard technique for that is called FISH testing, fluorescent in situ hybridization. And basically, this is a fluorescent staining technique where you stain the chromosomes, and if you look underneath the FISH, you'll see that each of the different chromosomes are stained a different color. And so if you're looking to see if one chromosome has linked up with another, you can see, for example, that there would be a linkage of a red spot with a green spot, and so that would tell you that that's a linkage between chromosome number 14 and chromosome number 4, the red and the green. And if the red one is linked up with a yellow, that could be a linkage with chromosome number 1, or I think maybe 16. So it's probably a 14-16 translocation. So you can use this method. It is a visual method, and so it's not a very detailed molecular method. We can use gene expression profiling to also assess the risk status of the myeloma. So if we go to slide number 32, this is what is the current classification of newly diagnosed active myeloma based on the presence or absence of those types of FISH testing results. And to keep it simple, the Mayo Clinic have come up with MSMART 3.0 in slide 32, where patients are standard risk on the right and high risk on the left. It's probably easier to identify the standard risk, which is just the presence of the trisomies, 3 chromosomes instead of 2, an 11-14 connection or a 6-14 connection, a couple of the earlier changes that we see as the disease is progressing. All of the later abnormalities are indicators of a higher level of risk, and you can see where there are multiple abnormalities. You can have categories called double hit or triple hit, where there are 2 or 3 or higher numbers of high-risk features present, which would identify increasing levels of potential risk. If we go to the next slide, just to give you an idea of what would we then do about that, for transplant ineligible patients, you can see that for the lower risk or standard risk patients, we would use Velcade, Revlimid, and Dex, and perhaps Revlimid and Dex for maintenance. Whereas if we had the higher risk features, we would add in bortezomib or a proteasome inhibitor as part of the maintenance. For the transplant eligible patients, it gets a little bit more complicated on slide number 34, where we would add in the options for transplant, and then the simple way to look at it is for the higher risk groups, instead of using Velcade, Revlimid, and Dex for deletion 17 and the higher risk groups, we would use Kyprolis, Revlimid, and Dex, and then we might be inclined to use that Kyprolis as part of the ongoing consolidation and maintenance as well. In closing tonight, as I move forward, just to summarize, well, where are we in this early disease setting, moving from MGUS to smoldering and to active myeloma? I think it's helpful to kind of set the stage for the whole of 2019, just to illustrate, well, where are we in terms of current best outcomes? And so on slide number 35, I have illustrated the longer-term results with the combination of Velcade, Revlimid, and Dex, which you can see from the previous algorithms I just showed you is the recommended frontline therapy. And this is from the Southwest Oncology Group study 777, and it just shows you that with the Velcade, Revlimid, and Dex, over half the patients are doing well beyond 7 years. And so this just kind of sets the benchmark of what we can expect overall with that type of triple therapy. And then if we look more closely at that on slide number 36, we can see that if a patient achieves at least a very good partial remission, VGPR, 60% of those patients are still alive and well at 8 years. And so if you get the VGPR with the VRD, then the outcome just with that frontline therapy is remarkably good. And then if we go to the next slide, 37, we can see that if you add in autologous stem cell transplant, ASCT, to that, as was done in a recent Spanish trial, you can see that you increase the chance that you can get beyond a VGPR down to MRD negative at 10 to the minus 6. And so you can see that if you go through VRD, ASCT, and then consolidation, 58% of the patients actually achieve an MRD negative status at 10 to the minus 6 level. So really excellent responses with current standard of care frontline therapy. And so if we go to slide number 38, we can see what that translates into, which is that if you have reached that negative at the 10 to the minus 6 level, you can see the green curve at the top there. That indicates that you are likely to have a really prolonged remission and excellent survival. And so this kind of sets the stage for newly diagnosed patients that just with the standard of care therapy, we do have high expectations for excellent outcome for a majority of patients. And so obviously in other studies we're looking at what about the higher risk patients and what are the additional options that they might need to consider. And so setting the perspective for this early disease situation, I'd like just to summarize in closing what are the current therapies and then what can we be expecting to talk about as we move through the year in the other Living Well calls. So in slide number 13, you can see frontline standard of care, Revlimid Dex or Velcade Dex, doublets for patients who are maybe older or more frail. If possible, a triplet, Velcade Revlimid Dex or Kyprolis Revlimid Dex, with or without an autologous stem cell transplant. Maintenance with a Revlimid or a Velcade plus carfilzomib or ixazomib, which is an excellent maintenance regimen. Really excellent to include any one of the proteasome inhibitors. And then obviously in relapse, we'll spend a lot of time talking about all the different new options that are coming along. And so in my final slide, just to summarize, where are we with all of this assessment of early disease in terms of looking at sensible treatment for myeloma overall? And I've divided in this future of myeloma therapy diagram into 3 parts. And over on the right, we have the different categories which really can do the best if treated as if they have active myeloma to get the maximum benefit. And so now these are patients in the middle who have CRAB criteria, who have myeloma-defining events, and then on the left, the red ones who have high-risk smoldering, who have that 2-20-20 characterization, and then over on the right, what is new is to intervene early at relapse and treat patients at biochemical relapse to try to get the best results for patients who maybe have had persistent disease with the current best therapies like the VRD transplant, which I just showed you. And then on the left of that, it's quite important to break down the patients with high-risk smoldering into those that might be treated and those who are lower risk, who can be followed along with the patients in green, who are the different categories of MGUS patients who really are best to be followed and observed and monitored, but assessed in all kinds of medical ways just to make sure what is going on in their case. And so with that overview summary, I'd like to stop, and we have a bit of time left for questions. So thank you for your attentions, and I'll be happy to answer questions that you might have. Thank you again. I'll turn it over to the moderator. Thank you.
Presenters, we have our first question. Comes from the line of Brenda Stubbs. Your line is open.
Yes, I am 82 years old. I have had smoldering myeloma for 21 years. 6 years ago, I had a breakdown of my immune system, so I have been taking IMWG on a monthly basis. What is the possibility of progression to myeloma for me?
Right. Well, thank you for that. A very important question. And so can I just ask, so with this IMWG, has that been very helpful in reducing your tendency for infection? Typically, that can be quite helpful.
Yes, it's been great. I am rarely sick.
Okay, that's wonderful. And so it sounds like you clearly are in one of those lower risk groups. So we would be paying attention to those things which I mentioned. How high is the spike in your blood? What is the percentage of plasma cell bone marrow plasma cells, and that free light ratio, and then some of the chromosome test results. So I would imagine that your doctor is checking some or all of those periodically to get a handle on, what your likelihood is. But even without knowing that, it sounds like you have already shown that you're falling into one of those lower risk groups. But to get some better information, you would need to have the protein test rechecked, perhaps a bone marrow test done, and chromosome testing done, just to get a little better idea. But truthfully, if you're remaining stable, that's the good news, and you don't need to do a whole lot unless there's a concern that things are changing.
Okay. Well, thank you very much.
Thank you.
Our next question comes from the line of Lisa Hatfield. Your line is open.
Hi, Dr. Durie. Thank you so much for all of this information. I'm just wondering if there is a difference when doing the imaging studies between lytic lesions and focal lesions, and with regard to the crab features, if the bone lesion criteria means one or the other, or if they're the same.
Okay, this is a really excellent question. And so when we establish this new criteria, which is the myeloma defining events, this is defined as having more than one lesion on MRI, which is linked to an increased likelihood of active myeloma. But truthfully, MRI lesions are not always those that are actually destroying the bone. And so a separate criterion that we use is lesions that show up on whole body low-dose CT or on PET CT. And frankly, these are much clearer and stronger indications of active myeloma, so that if you have evidence of actual bone destruction, what we would call focal lesions, that is much more important than what could be a hot spot on a PET scan or an MRI, where there could be an area of myeloma in the bone marrow, but it's not necessarily starting to damage the bone. And so if there's a question about active myeloma, I do think that the CT scanning to look at the bone is the most direct and precise way to assess that particular point. Okay?
Thank you.
Okay.
Our next question comes from the line of Judith Leder-Handler. Your line is open.
Yes. Hello, Dr. Durie. My husband had MGUS for many years, and then gradually the level of the gamma globulin rose over 3, so he began to receive treatment. And how do we decide whether to do a stem cell transplant autologous?
I'm sorry, I missed the last part. How do you decide to do?
Whether we should do the autologous transplant.
Oh, autologous stem cell transplant?
Yes.
Okay, I think that obviously is quite a tricky point. So I'm assuming that along the way the protein level went up above 3, and then there were some other indicators that indicated evidence of myeloma.
Yes.
And then there has been treatment given for myeloma. I guess maybe Velcade, Revlimid, or Dex, or what was used for the treatment?
KRD for 4 cycles.
KRD, okay, so excellent 3-drug KRD, kind of top of the line type of treatment. And so then the question is, what additional benefit can you get from the stem cell on top of that? And so one important part about the study, the French study, which looked at VRD plus or minus transplant, was that if the patient achieved an excellent response, particularly like MRD negative, then that patient, even without the transplant, did well. So the most important thing was to have an excellent response. And so if there has been an excellent response with the KRD, particularly if it's MRD negative, then one can say that, well, maybe you don't need to rush ahead with the transplant, okay? So if you've had an excellent response, then that would be a situation where it's up for discussion, maybe harvest the stem cells and wait for later. And we don't have 100% answers on those 2 options. So
Right.
So the most important is to assess the level of response so far.
Okay. All righty. Well, the harvest has been done.
Oh,
okay.
Wonderful. Okay,
yes.
So it sounds like see what the level of response is, and then decide if there's residual disease, maybe go ahead, and if not, maybe go ahead with consolidation or maintenance. Yeah.
Perfect. Okay, thank you.
But you can see that the stem cell transplant is certainly not mandatory. Okay.
Very good. Okay, thank you.
Our next question comes from the line of Roger Goldstein. Your line is open.
Thank you. Dr. Durie, I first want to thank you for all you do towards myeloma research and patient education. Ever since I was diagnosed and found your webinars and information, it's been very helpful.
Well, thank you. It's my pleasure, obviously. So thank you for that.
You bet. So in 2008, I was diagnosed with MGUS. I did not have a bone marrow test until 2015 after I moved to California. At that time, I had between 10 and 15% in abnormality in my marrow, so it was classified as smoldering multiple myeloma.
Right.
My question is, you've mentioned chromosome testing a couple of times, and that's never been discussed with me or my doctors. Is that something that they would have done, or I should advocate for in order to give me an idea of what progression might look like?
Yeah, I think so. Yeah. I think it's definitely an added factor that might be helpful. It might have been done, and I would say certainly should be done when you have a follow-up bone marrow. I would imagine you're continuing to be followed and monitored, and so I would imagine that there would be a plan to possibly repeat the bone marrow maybe in a year or, at some point here to repeat the bone marrow, and I would certainly do the chromosome testing on that. The other thing that you bring up is that when you look at that percentage of the plasma cells in the bone marrow, it can be a little bit spotty in the bone marrow, and so sometimes it could be 10-15%, and then you might repeat it, and then it might be 10%, or then again it might be like 20%. And then, as I mentioned, if the bone marrow percentage of plasma cells gets up to 20%, then that is a concern of maybe progression, and then particularly if that protein level is going above 2 and the free light ratio is higher. And so I think that those are the things to watch and discuss with your doctor. But just monitor along. Although you could tell from my talk that I'm certainly an advocate of the potential benefit of early intervention. We certainly want to be really clear that intervention is needed, because we just heard from an 81-year-old lady who's been followed along for quite a long time without any kind of intervention. So we need to have a careful balance between intervening early to do a really good job and then versus watching closely.
Yeah, thank you very much. That's where I've kind of been in that, 11 years of just following. I'm being followed every 4 months now, and I certainly don't want treatment or the need to have treatment if it doesn't exist, right? Exactly. But then there's an unknown curiosity, right? Is there some other piece that I don't know? And the chromosome, I'll ask on my next visit about that.
The other would be, I don't know if you have it done, but would be a whole body low dose CT or a PET CT scan just to complete that imaging picture. But you can see that these are just markers to give you confidence that indeed it's reasonable to continue to monitor.
Okay. Yeah, and I've had 2 PET CT scans, and both times nothing showed up.
Okay,
yep.
So that's very strong support for continuing what you're doing, which is to watch closely. So very good.
Okay.
All right.
Thank
I think
you.
we have time for maybe 1 or 2 more questions here, so I'll try to move along quickly on my side.
Thank you. And your next question comes from the line of Evelyn Ehrenreich. Your line is open.
Thank you. Thank you very much. So I have been diagnosed with MGUS for about 13 years. It's reasonably stable. Initially, my bone marrow percent was 6%.
All right.
And in 2012, it went up to 10%.
Uh-huh.
And I haven't had another bone marrow since then. But I do have several risk factors that you identified. One is that it's IgA.
Uh-huh.
The second is that there was a 1Q plus on the genetic analysis.
Okay.
And then the lambda kappa lambda ratio is low, so it's classified as lambda plasmacytosis.
Uh-huh, yeah.
The ratio wasn't that abnormal. It was about 0.24, and I believe the reference range starts about 0.26. So I'm just wondering, though, with some of these higher risk factors, I guess the IgA and the 1Q plus, whether there's any more frequent or monitoring that should be done.
These are certainly not definitive, and I think that one of the reasons that we have this IMWG study going on right now is to try to give a little bit better precision, and so we're continuing to look at the patients to see if we can come up with some combination of factors that can give us a little bit stronger guidance for someone like yourself, both to guide our monitoring, but also when there is a need to intervene, that we can be kind of secure that it's appropriate. One test, which I think I'll just draw to your attention, which seems like it can turn out to be very helpful, a new test, is to look for plasma cells in the blood. We've learned that patients with active myeloma have plasma cells in the bloodstream, and so it's now possible to measure those and see if they're present and then how many there are. And so this is an extra test to maybe help guide in situations where there might be an open question. And so if you'd like to do that, you could contact the IMF. Basically, samples can be sent to the Mayo Clinic right now for that kind of testing.
Okay, thank you.
Yeah.
And I'm just wondering also why my blood test reports keep saying M spike not observed, but then it also says that a band is noted in the IgA region.
It might be IgA is a little bit trickier to measure. One test you might ask for is the heavy light test. Using the heavy light test, you can get a little better handle on the level of the IgA. 'Cause sometimes the IgA is a little bit tougher to measure.
Okay, that's different than the free light chain, then.
Yes,
okay.
That's the heavy. That's the IgA versus the light chain. Yeah, so it's a little different test.
Okay.
we're also looking at something new I didn't talk about today, which is a mass spectrometry, which is another way. But maybe if you're interested in some of these things, you might want to call the hotline and we could get you a little bit more information about some of these extra tests, okay?
Okay, thank you. Thank you
All
very
right.
much.
Well, I think that we're coming to the witching hour here by my timing. And so, Susie, if you're still on the line,
I am.
I turn it over to you for your closing thoughts, closing remarks.
Well, thank you very much, and thanks to everybody who joined the call tonight. So I would like to thank our presenter, Dr. Durie, for the outstanding and very informative information that he shared with us all tonight. I'm sure everyone on the call tonight must have appreciated the information, and most likely a lot of tonight's listeners will certainly have some follow-up questions. So as Dr. Durie was suggesting, and I do as well, to please call our info line, and they'll be able to help you. They're wonderful, and they have a lot of information. The toll-free number for the info line is 800-452-2873. Another really fantastic way to stay abreast of all the new data and how it impacts your treatment options is to attend one of our patient and family seminars. Our next one will be in Los Angeles on August 23rd and 24th, and after that we'll be in Charlotte, North Carolina on September 6th and 7th. And if you can't make it to one of those, my colleague, Kelly Cox, holds regional community workshops all across the U.S., and I suggest you go to our website and see if there is one near you. And while you're at it, check out our new website. Just go to myeloma.org. We're very proud of this new site, and it was like giving birth to an elephant. It took a long time, but it was worth it. So again, thank you so much to Celgene and Takeda Oncology. And before we close, I want to thank our wonderful support group team here at the IMF, Robin, Kelly, Nancy, another Kelly, and Jonathan, who work with support groups all across the country, helping them in so many positive ways. So that's it. Have a wonderful evening, and I hope to see you all soon. Take care.